So, yeah, so, and I don't
My share some you just shut me.
share it in a Zoom.
Oh, but it not come up on YouTube.
You know, see. I just actually had it come up with see those things. Somebody. Yes. Yes, it is.
So this is it. Try spotlight my video
And then we spotlight it.
on when the Zoom. When the Zoom. It's up here, so yeah, I'm participant. Okay. Samir.
Sure.
Yeah, right click on second spotlight. The other one.
No, but I mean,
I click the three dot. Yes, spotlight. Right. Alright, look if it show up on YouTube. Oh, yes. Just delay.
I knew that. So that I'm going to do no things. 1, 2. What let me see something. So and then they get short can do that video first nothing get access to
The YouTube.
Guys, yeah, still says yeah. I'm still yeah. Stream, I guess stream.
Oh, damn, sure.
Cause you know.
Yes. I think you just share now.
But me not see that. Yeah.
I'm in place, ready to do what you would like me to do. We're on Are we the only ones here? Can you hear me, Moret?
I think we're all on. All of those of us who are on the program are on.
Yes. Our guest speaker is there as well.
Yes, our lecturer is here.
Okay.
We can start. We're presently being streamed on YouTube. Live. We're live right now.
All right. So we can do that. We can start. All right. Good afternoon. It's a little rainy in my part of the corporate area. I'm not certain what it is like where you are, and if you're on YouTube, wherever you are, we thank you for joining because this is a very important topic, and I guarantee you're going to be getting outstanding information, helpful information, informative information. It is, the first time I became acquainted with sickle cell was with somebody's son, and the challenges that the parents faced taking care of that young man. He's now an adult person, and how many times he had to be taken to hospital and the pain that he would suffer. And then recently, I was listening to a newscast right here in Jamaica where a mother and her daughter were being interviewed about the challenges the daughter was facing at school because she needed to go to the bathroom regularly, and the teachers didn't quite understand why. So it is very important that we have this kind of discussion. I hope we have teachers on, or we'll get teachers to join. And if there's any way those of us listening can touch a few people to say, hey, come on, this is happening. Then, by the way, Moret, you could perhaps just tell what is the YouTube link?
It's the Ministry of Health YouTube link.
Okay, the Ministry of Health YouTube link. Right. We'll hear much more about that. Those are just my opening comments. I'm Faye Ellington. I'm the moderator. And like you, I am willing to learn. I say you, listening on YouTube, because we need to learn so much more. What is sickle cell trait? What is sickle cell? What is all of that? So, but, before we start, we normally have prayer. And I'm going to ask Mrs. Natalie Mitchell Warren, educator, author, and a member of the Sickle Cell Foundation, to ask for God's blessings on the occasion.
Bless the Lord. Good afternoon, everyone.
Good afternoon.
Let us pray. Our God and our Father, we want to exalt and thank you for this day, for you are God and you are God alone. We thank you for your many blessings and your mercies that has kept us and enabled us, God, that at this moment we're able to come into this fashion. Lord, as we come today for this program, we invite your presence to be with us. Lord God, we can't do anything without you. It is not by might nor by power that we're able to accomplish anything, but it is by your Spirit, mighty God. And so we pray that your Spirit will hover over us this afternoon. I pray, Lord God, that you will sit up on our speaker for today. I pray that, God, you will give her wisdom, knowledge, and understanding. I pray that there will be clarity in everything that she has to share today, mighty God. I pray that you will navigate this program with our moderator. Let your wisdom, mighty God, take precedence today in the mighty name of Jesus. Father, we come before you and we are cast, oh God, with this infirmity. Oh God, like Paul said, there is this thorn in our flesh. But Lord God, you reminded Paul that your grace is sufficient for him. And so today we lean upon your grace, mighty God, knowing that your grace is sufficient for every sickle cell warrior, mighty God. And so I pray that every person that will tune in today to listen, Lord, you will give in them, you will, oh God, develop in them a heart of compassion in the name of Jesus. Let there be empathy in the name of Jesus. Let there be wisdom, mighty God. Let there be strength for each warrior this afternoon in the mighty name of Jesus. I pray, Father, that whatever nuggets we will get today, you will help us to put them into practice so that, God, as we continue to rest upon your grace and your wisdom, mighty God, you will continue to strengthen and favor and sustain and preserve us for your your kingdom, mighty God. For we have work to do. And though there is this thorn in our flesh, we continue to soar, we continue to thrive, and we continue to let your name be glorified. So we lift you up today, mighty God, and we ask you to have your own sweet divine way as we commit ourselves as vessels into your hands for you to use us now. In Jesus' name we pray. Amen.
Amen.
Thank you.
You know, as I listened to you pray, my mind just went really right back to when I first came across information on sickle cell. And who cannot forget? No one can forget if you came in contact with a very, very empathetic professor. You know exactly to whom I refer, right? Right, Moret?
Professor Graham Sargent.
Professor Graham Sargent. So long before that young man I made mention of and his family, Professor Graham Sargent, as a young broadcaster, I had the opportunity to interview him on JBC television and JBC radio. And he opened my eyes, not only to the work that he had been doing with all the babies who were born across Jamaica, and where he would go into the hills and the valleys and all of that, but to what this thing was all about. And then after that, I met Camille Daly. So I was interviewing Camille over the years, may have done 2 or 3 or 4 interviews with her. And there was another young woman with her who would come to just spread the word and inform us about sickle cell disease. Is Camille with us this evening, this afternoon? It's not yet evening.
She's in class. She's lecturing now.
Oh,
So she's
oh
unable
man,
to
can you
join.
imagine? Here is somebody with sickle cell who's fought and who has done so much, and she's now lecturing, you know. So the thing is, with the right information, the right support, and the medical help, you know, sickle cell, those persons with sickle cell can really lead a useful life. Thank you so much, Natalie Mitchell-Warren, for your prayer. Now, Maurette Wright is a person who got me involved in this project this afternoon, and she again is a warrior for this. So Maurette, might I invite you please, as co-founder of the Sickle Cell Foundation of Jamaica, to bring your welcome and greetings.
Thank you so much, Auntie Faye. Alone we can do so little. Together we can do so much. These timeless words from Helen Keller remind us of the extraordinary power of unity, collaboration, and shared purpose. Good evening, everyone. It is my distinct pleasure on behalf of the Sickle Cell Support Foundation of Jamaica to warmly welcome you to the 2025 Annual Sickle Cell Lecture. This event is proudly hosted in collaboration with the Ministry of Health and Wellness, the Caribbean Institute for Health Research at UWI, and the Sickle Cell Unit. We extend heartfelt greetings to all our participants joining online, patients, families, healthcare professionals, researchers, policymakers, and supporters here in Jamaica and across the globe. Please take a moment to write in the chat the category you represent and your country. So whether you are a patient, a healthcare worker, policymaker, just write that in the chat. Your presence underscores our shared commitment to advancing care and strengthening communities. We are especially grateful to our partners for their steadfast support in shaping the national, regional, and global response to sickle cell disease. I must commend the outstanding work of the Sickle Cell Technical Working Group in advancing the Ministry of Health and Wellness's mandate to improve the sickle cell program in Jamaica. You will hear more from Dr. Carol Lord, Chair of the Technical Working Group, in her greeting. A very special acknowledgement to our distinguished lecturer, Professor Monica Asnani, Director of the Sickle Cell Unit at the University of the West Indies. Professor Asnani is a visionary leader whose work continues to touch the lives of countless individuals and families affected by sickle cell disease. Just this week, she played a central role in the Sickle Cell in Focus Conference, an internationally recognized platform for education and exchange. Prof, we're honored to have you with us this evening. I must also warmly welcome our moderator, veteran broadcaster, Faye Ellington, Auntie Faye. You heard her how passionate she is about the topic. She will expertly guide us through this evening's program and ensure an engaging discussion. This year's Sickle Cell Awareness Month theme, Transforming Care and Strengthening Communities, is both timely and inspiring. It reminds us that advancing care goes beyond clinical excellence. It is also about empowering patients, supporting families, and building resilient networks of care. Our Awareness Month activities have been intentionally aligned with this theme, from our blood drive, our sickle cell screening, and training of school nurses and healthcare workers to tomorrow's empowerment meeting, spotlighting the success of 3 remarkable individuals living with sickle cell. Tonight's lecture, Renal Realities, Understanding Kidney Complications in Sickle Cell Disease, focuses on one of the most pressing and often silent challenges faced by individuals with sickle cell. Kidney complications are progressive, life-altering, and too often overlooked. By highlighting this issue, we foster greater awareness, stronger advocacy, and more effective strategies to transform patient outcomes. As co-founder of the Sickle Cell Support Foundation of Jamaica, I remain humbled by the journey we've taken together, raising awareness, educating communities, and standing with individuals and families affected by sickle cell disease. Earlier this year, we mourned the loss of Professor Graham Sargent, the pioneer and father of sickle cell disease, on whose shoulders we stand. May his soul continue to rest in peace. It is our hope that as we learn and engage this evening, we also renew our commitment to ensuring that individuals living with sickle cell disease can thrive, supported by care that is compassionate, informed, and transformative. On behalf of the Sickle Cell Support Foundation of Jamaica, thank you once again for joining us. Thank you to our partners, and thank you, Professor Asnani, for leading us in this vital conversation. And so, as Helen Keller reminded us, together we can do so much. Let us move forward, united in purpose, to transform care and strengthen communities. So welcome everyone. Let's look forward to an enlightening and impactful session together. God bless you.
Thank you, Maurette Wright. Thank you very much. That was thorough. You had a broad welcome for everyone, and who could have done it better than you? You. Thank you so very much. You know, while you were talking, I found the link and I've put it on Facebook. Yes, because I think I want as many people as possible to see it. I'm going to then put it on, I still call it Twitter. All right, I'm going to put it there as well. The more people we can pull in to listen to our guest speaker and to listen, Dr. Carol Lord will be speaking momentarily. I think the better it will be for us just to get the word out. And I'm going to put it in some WhatsApp groups that I have. It's so important. So maybe those of you who are on, you could perhaps start sharing that link as well. Thank you so very much, Moret Wright, co-founder of the Sickle Cell, and there's an S there. Sickle Cell, come tell me.
Support Foundation of Jamaica.
It used to be Sickle Cell Foundation, and there's Sickle Cell Support Foundation. Thank you. I've been with it for too long, so sometimes I can't remember what the most recent term is. So then, Dr. Carol Lord, you are with us, and I know you're waiting to give your remarks. You're chair of the Sickle Cell Technical Working Group in the Ministry of Health and Wellness. And I'm certain you have information that you are eager to share with those of us who have a listening ear at this time. So might I welcome you, Dr. Carol Lord.
Yes. Thank you so much. Thank you so much. Good evening, everyone. Thank you, our dear, faithful chairperson. We are so grateful to have you every year. And so good night, everyone. I greet you warmly on behalf of the Ministry of Health and Wellness and as chair of the Sickle Cell Technical Working Group. And we have the Sickle Cell Support Foundation with our co-founder, Ms. Moret Wright, and our co-chair, Professor Jennifer Knight Madden. We also have the other members of the Sickle Cell Unit, Professor Monica Aznani, Dr. Leslie King, and the other members. We want to say welcome. Also in the part of the Sickle Cell Technical Working Group, we have the regions and other partners that play such an important part in this collaboration. A very mobile, influential collaboration as we offer care to persons living with sickle cell. And so it is my honor to bring greetings as this year's annual Sickle Cell Lecture under the national theme for Sickle Cell Awareness Month that we look at transforming care and strengthening communities. First, let me recognize our gracious moderator, Ms. Faye Ellington, who is no stranger to us, our partners from the Sickle Cell Support Foundation, the Sickle Cell Unit at the University of the West Indies, colleagues from the regional health authorities, and our online guests. You have joined us this evening for a very informative session. Sickle cell is not only a health issue, it's a community issue, a family issue, a national development issue. In Jamaica, we have 1 in every 150 person living with sickle cell disease, and 1 in every 10 carrying the trait. These numbers remind us as to why we must remain steadfast in raising awareness, expanding services, and supporting families living with this condition, hence the effective technical working group members. The Ministry of Health and Wellness continues to strengthen its response through newborn screening. The newborn screening is across 100% of the birthing facilities within this nation, both public and private, and we reach over 25,000 babies each year. So within the last year, we had 99.9% coverage of babies being screened for sickle cell disease. There is early linkage to care, whereby we ensure that once a diagnosis is made, families are connected to clinics and parish coordinators for this specialist support. These parish coordinators ensure that there's complete linkage to care. As part of the Ministry of Health and Wellness, we have life-saving vaccines free of cost, protecting children from sickle cell disease, infections, very worse infections that could otherwise be fatal. In fact, this is one area that actually has expanded the life expectancy of children living with sickle cell disease. As it relates to our pregnant women, we have specialist care once they're diagnosed with sickle cell disease. Because of the high-risk nature, they are assigned to high-risk clinics, whereby the pregnancy can be managed even more closely. We have to say the super specialist clinic, high-risk clinic. In addition to that, in collaboration with the National Health Fund, we were able to offer hydroxyurea therapy, which is a game changer in the lives of persons living with sickle cell disease. And to cap it, we have ongoing training for healthcare workers to improve early diagnosis and treatment of complications. Because we not only reflect on medical intervention, but we also remember the human side of sickle cell disease, the families who often face stigma and discrimination and the emotional strain. And so not only for the persons and adults, but also for the children at school. And as our chair has all brought to our attention, the school child with that issue. And so what we have for tonight's theme, it is so fitting because transformation requires both care and support from the community. Medical advances must be accompanied by compassion. It must be able to break down these barriers. And so this annual lecture has become a platform to bring science, to bring practice, and to bring the community voices together. And so tonight's focus on renal realities, understanding kidney complications in sickle cell disease is particularly timely as individuals with sickle cell disease are living longer and thanks to improved care. Chronic complications such as kidney disease require greater attention and coordinated response. Our guest speaker, Professor Monica Aznani, will tell us more about that. And so to our Sickle Cell Support Foundation of Jamaica and the Sickle Cell Unit, I want to say thank you for partnering with the Ministry of Health and Wellness Jamaica. Thank you for supporting the vision, and thank you for being resilient in keeping this issue at the forefront of the public dialogue. As we gather here virtually, I encourage each of us to leave not only informed, but also inspired, and to share what we have learned, to advocate for our patients and for families, and to continue to build the kind of health system and community where no one lives with sickle cell disease feel left behind. No one should be left behind. And so on behalf of the Ministry of Health and Wellness, I extend heartfelt appreciation to our partners and to our guest speaker, to our chair, and to our keynote speaker for this evening, Professor Monica Aznani. We say thank you for accepting this offer, this request. And so may tonight's lecture deepen our knowledge, strengthen our partnership, and more importantly, move us one step closer to transforming care and strengthening communities in Jamaica. I want to say thank you so much for being here, and God richly bless you. Please share the word, as Faye said. Twitter, Facebook, everything. Let others join as our keynote speaker, share on renal complications. Thank you.
Thank you, Dr. Carol Lord. And I really, really hope that we will reach quite a number of people in Jamaica and beyond the shores of Jamaica. You know, one of the things that people are a little confused about, and I'm certain our guest speaker might touch on it a little bit, is what's the difference between sickle cell disease and what is the sickle cell trait? How do I know if I have that? I see Professor Asnani, her eyebrow just went a little up a while ago. She says, what is Faye doing? That's not what I'm here to lecture about. But, you know, perhaps just to say what it is, because in talking with people, I recognize that people still don't know. They don't know. And it is not that information is not available, but the information is not reaching the people, and it's not your fault necessarily. It's that people are using information for different reasons, primarily for entertainment, and something like this that is so important, they don't usually connect with. And perhaps somebody should, I have put it on Facebook, I've put it on Twitter, maybe somebody with a TikTok account should put it out, because that has quite a wide appeal, particularly to younger people, not only, but particularly to younger people. Well, we are all anticipating our guest speaker, our keynote speaker for 2025, this annual sickle cell lecture. And we have a member of the team who will now introduce our keynote speaker, Mr. Davion Cole. Might I ask you, educator and a member of the Sickle Cell Foundation of Jamaica, to now tell us, who is this person? Mr. Cole there?
Yes,
Yes,
good
I'm
evening,
seeing you,
everyone.
Davion. Good, wonderful. Who is our guest
Good
speaker?
evening. Well, Monica Asnani is a professor of family medicine and epidemiology and the director of Sickle Cell Unit of the Caribbean Institute for Health Research at the University of the West Indies in Jamaica. She is a graduate of the University of the West Indies and was awarded the MBBS degree in 1992. Her thesis work leading up to the award of DM Family Medicine in 2006 examined the quality of life of patients with sickle cell disease. She completed in 2014 her PhD in epidemiology with a focus on the epidemiology of sickle cell nephropathy. She joined CARE, which is the Caribbean Institute for Health and Research, in 2003 and has over 22 years of experience of providing clinical care for persons with sickle cell disease. Her focus of research is 1, psychosocial outcomes and determinants in sickle cell disease, and 2, sickle nephropathy. Her work has advanced understanding of what factors may worsen renal function and best methods to screen early for renal disease in sickle cell disease. Predictors of renal function decline in sickle cell disease and has sought to validate methods to determine presence of early sickle nephropathy. Her current projects include examining hydroxyurea utilization, enablers and barriers in Jamaica, social determinants of adult outcomes in sickle cell disease, renal function in sickle cell disease, and aging in sickle cell disease. She believes that a major outcome in patient care is improving the quality of life of individuals who present as patients to you as physicians. This includes not only managing disease, but enabling them to live fuller and richer lives through behaviors that will build wellness. Her passion is therefore interacting with persons living with and affected by sickle cell disease through for alike this session tonight. So please put your hands together and welcome our keynote speaker, Professor Asnani.
All right, that's our hand up. Good evening. This evening is almost 6 p.m. Good afternoon, good evening, everyone. I just want to take a minute to ask Moret. Moret, your hand is up. Did you want to say something? No.
No, Prof.
Thank you. It's an absolute pleasure and again an honor to be doing this lecture. I think I offered myself to the Support Foundation. Kidney disease is a special love for me, for whatever reason. There are many reasons, but it's really an honor to be given this platform, to be offered here, and to be given so much love and respect this evening. Before I begin, I want to say when I saw again that Faye Ellington is going to be chairing, once again, you are a champion for us. And before you said it in your 2 intermissions when you spoke between other speakers this evening, just in the last few minutes, I said to myself, we don't know how to communicate well. You already told us, hey guys, I am going to put this on Facebook, I'm going to put this on Twitter or whatever they call it now, etc. We don't know how to communicate well, and that is what is needed. In your second bit, you said people are still not understanding what sickle cell disease and sickle cell trait may be. And we have learned either as researchers or clinicians, and clinicians better know how to communicate at least one-on-one with their patients and with the families that they interact with. But on a broader level, how do we communicate information in a way that is clear? So, Miss Champion, we ask you to guide us. More work on your plate, because this is where we really lack. I work at the University of the West Indies, and you heard I work at Caribbean Institute for Health Research. We are an entity that should produce research regarding, what's happening with health in our region, not only in Jamaica, but nationally and region in our region, but also global. And in the recent few years, so we know to some extent to do research, to do excellent research, but we don't know how to communicate it. In the recent few years, we are asked more and more by the university, by our stakeholders, whether it's the Ministry of Health, whether it is communities, to communicate the information properly. And we still don't have the skills or adequate resources to do so. And I do believe if we don't communicate, then we have lost half of the battle. It's important to produce evidence, but it's also important to explain it to our communities that are the end users. Those are the ones who require this information, and also to policymakers who need to understand our information in a way so it could be actioned. Ms. Ellington, you will need to continue to guide us. Maybe we'll have a one-on-one again, but I am absolutely thrilled that you're with us again. It just shows your love for us. Thank you for honoring Prof. Graham Sargent again. We miss him. He's a guru, he's a father, and we are beyond proud that we can own him. Even though he came to Jamaica from the United Kingdom in the early 60s, he's from the UK, but he made Jamaica his home, and sickle cell remained his passion to his last day. Even though someone said, rest in peace, Prof, I don't think he can ever rest. I think his passion for sickle cell continues to drive work, definitely in Jamaica. And through all of these fora, he supported the unit, he supported the Support Foundation, he supported governments around the world. He's a well-known leader in the world of sickle cell. We honor him, we mourn him, and we miss him a lot, because Ms. Ellington, what you may not know is that he worked up to 2 weeks before his passing. We were exchanging emails on a project.
I'm not surprised to hear that, because maybe 2 or 3 years ago, he invited me up to his house, he and his wife, and we were there talking. And how can you help more, Faye, is what he was saying. So you're right. He is still working, and his legacy is working for him.
Legacy is working for him through people like me, through people like you, people like Moret and others on this call, and many of the patients that he has looked after and brought them life and hope. So we honor him once again today. Let me start the talk, and I hope I'll be able to do justice, and I'll be able to, maybe make a little bit of sense, make it a little bit clearer. I remember when I start sharing, I will not see anyone's hand or so. And we are streaming, so I can't see any questions. But let me know if you don't hear me. Just jump in and say it to me, because I might just be speaking to myself if anything happens with technology. Let me put this in slide show. The second thing is that I have personally invited Dr. Laurie Fisher, who is a consultant nephrologist. She is which means she's a kidney specialist, which I am not, which Mr. Cole would have told you I'm a family physician. But I've asked her to come on, and she's been kind enough to join our session today. So when at the end of my talk, I'll ask her to say a few things that I know I would not have brought clarity to. Thank you, Lorianne, for being on the call with us today. So let us begin. Renal realities, understanding kidney health in sickle cell disease. I want to start, and I'm happy I did it because Faye mentioned it a few times. I want to start the first few slides looking at some basic facts about sickle cell disease. And it is that it is one of the most common monogenic disorders worldwide. Now, we have thousands of genes in the human body. And our genes are what determine everything about us, how we smile, what color our hair is, what length, how tall we are going to get, what color our eyes are, how our liver is going to behave, etc. And so we have thousands of those genes in the human body, and a slight defect in one single gene is what happens to give us this vast disorder called sickle cell disease. And this single gene change leads to a change in the hemoglobin in our red blood cells. Our blood has many components. It has the liquid, the fluid around it, but it has many cells in there that have different activity and different function. One such cell is the red blood cell, which is what you're seeing here. These nice round donut looking cells, that's a red blood cell, and it's called red blood cell because it's supposed to look red, and it carries oxygen around our body. And we all know that oxygen is life. If we do not breathe in oxygen, if we cannot breathe in oxygen, we will not live. Hemoglobin is a protein in the red blood cell that binds the oxygen that we breathe in and carries it throughout our body. And
Prof, might I interject? Your
Yes.
slide is not moving.
Are you not seeing the first slide, sickle cell disease basic facts?
No, we're seeing your title slide.
And it's not centered. We're seeing some of the. Did you put it to there you are.
You're seeing the
That's
second
better
slide,
now.
but it is not in slideshow.
Correct, it's not centered.
Because
So
it's not
some of the
slide-
words are missing.
Really? Okay, hold on. Now, it is in slideshow for me. Are you seeing the presenter view?
Some of the words
Are missing?
initially on the left they were, but now on the right.
Oh, why is it in this view?
I'm not
no,
certain.
view,
Let me hold it
display
up some more.
settings, swap presenter view. Is that better?
No.
What are you-
That's it. That's it.
Are you seeing the full thing now?
That's it now. That's it.
Okay, okay. You're seeing the full thing and you're not seeing my next slide. You're only seeing one
No,
slide.
just seeing the one that says sickle cell disease basic facts.
Okay, great.
And it's now properly centered. Nothing is cut off.
Do you see the second slide, the third slide now? Inheritance?
Yes, sickle cell disease inheritance, correct?
Right, great. Perfect. I think this will work. So we were saying these are the red blood cells that you're seeing in the photo here on your left. And so sickle cell disease, because it is a disorder of blood, it's a multi-system disorder because wherever blood flows, then the disease can impact those areas. And so that is all over the body. The disease is multi-system and it can be quite severe, with many acute problems that we all know of, acute problems such as painful crisis, acute chest syndrome, stroke, etc. But it can also lead to chronic, ongoing, and progressive organ damage, damage to the eyes, damage to the kidneys, to the heart, to the liver, etc. How is it inherited? Okay. So we said it is due to the fault of one gene. Where do we inherit our genes from? We inherit it from our parents, okay? So sickle cell is an inherited disorder, which means it is genetic, it's inherited. You cannot catch it in any other way. You can't catch it from a blood transfusion. You have to inherit it. And you inherit it by getting one abnormal gene from each parent. For you to have sickle cell disease, you have to have two sickle cell genes, one coming from the mother, one coming from the father. One parent cannot pass on sickle cell disease to you. Okay, many times, I think it is lessening. I hope this myth is lessening. A lot of times a baby got diagnosed with sickle cell and the parents started a blame game. The father might say, no, I have no sickle cell in my family, it's coming from the mother. Or the mother might say that, nope, I've never heard of this disease in my family, it is coming from the dad. but that cannot happen. For a baby to be born with sickle cell disease, one of the two abnormal genes come from each parent. The mother passes an abnormal gene and the father passes one abnormal gene. And that is for you to get sickle cell disease. If a baby is born with just one abnormal gene for sickle cell, baby got an abnormal gene just from one parent, got a normal gene from the other parent, that baby has sickle cell trait. They do not usually have any problems for the most part, okay? They do not have sickle cell disease. So let me show it a little bit better. Sickle cell disease, sickle cell disease, there's various different types of sickle cell disease, and you see them listed here: SS, SC, S beta thal, S beta 0. But sickle cell trait occurs if you have one abnormal S gene and the other is the normal gene. Normal hemoglobin gene is the hemoglobin A gene. Abnormal sickle cell gene is hemoglobin S gene. So if you have two S, that is sickle cell disease. But for you to have the trait, which usually is asymptomatic, for the most part, persons who carry the trait will have no problems, no medical problems. They may have a couple of things, but for the most part, they are asymptomatic and remain well. What happens when a person is born with sickle cell disease? Okay, so the normal red blood cell, as you can see here, I don't know if you're seeing my pointer. Are you able to see my pointer at all? No.
Yes, we're seeing it.
Yes, we're seeing it.
Yes.
We're seeing it.
Good. So here is the normal red blood cell. It normally looks like a round donut shape, okay? But in sickle cell patients, it assumes a sickle shape or a banana shape. So what's the big deal about having a banana shape or a donut shape? What's the big deal about a shape? It is not only the shape of the cell that changes in sickle cell disease, it is also other characteristics of the cell that change. The sickled cell is much more rigid, okay? It's a lot more sticky as well. So our blood vessels are very fine in many areas, okay? Very tiny and very thin. For our blood to traverse, the normal round sickle cell can usually move itself, just kind of maneuver itself through this fine circulation. The sickled cells are more rigid, so they are not very amenable to pushing through these fine vessels. They are rigid, okay? And they're also very sticky. They can stick to each other and they block circulation, okay? What we call vaso-occlusion or occlusion or blocking blood vessels, all right? So that is one thing, okay? And when they block blood vessels, that is when a person goes into severe pain, all right? The other thing about these rigid and sticky red blood cells is that they also have a shorter lifespan, whereas a normal red blood cell in persons without sickle cell disease can live up to about 4 months, about 120 days. A sickle red blood cell lives between 10 to 20 days, so they have a shorter lifespan, okay? Yet sickle cell disease sounds simple, but it's a very variable disease. So I said to you in 2 slides back that there are different types of sickle cell disease, the SS, where 2 S genes are inherited, one from the mother, one from the father. That's the commonest type of sickle cell disease, but there are other types. The other common one is SC. So the commonest one in Jamaica is SS and around the world. When it comes to sickle cell disease, SS is the commonest type of sickle cell disease. The next common one is SC disease, and then you have others called S beta thalassemia and many other variants of sickle cell disease. But what you're seeing there are the common ones. Usually, SS and S beta 0 thalassemia tend to be the more severe types of sickle cell disease, and SC and S beta plus thalassemias tend to be milder in their presentation. But yet, there are many patients with SS disease who might have mild disease, And there are patients with SC disease who have very severe disease. Sometimes you might look at a SC and wonder, is this actually an SS? And we might say, boy, let's just test this person again. But no, they have SC and yet they have severe disease. So there's a lot of variability. So we can get fooled, and we must not allow ourselves as healthcare professionals to get fooled. So even within genotypes, as we said, different. So even within SS, you can have very variability in how severe it is. Some people with sickle cell disease may just be found incidentally on some kind of a health insurance test or something else that they were getting tested for. There have been patients, especially with SC, diagnosed in their old ages. They might come in with some complication and the doctor decides, let me do a sickle test. And there are many different things that severity, I won't speak to the rest of it, is not that important right now, but just to say that the disease can be very variable, especially important for patients to understand and especially important for healthcare providers to understand. So don't sit down and say, I have SC disease, and Faye, a lot of people in Jamaica who have SC think they have sickle cell trait, or they think they have a trace of sickle cell disease. Nothing don't go so. If you have SC disease, you have sickle cell disease. It is just the SC type. It might be milder, but it does not mean that you don't have sickle cell disease. It is not the same as sickle cell trait. And this is just one slide to show that you can have sickle cell complications all over the body. If you have a problem in the kidney, in the eyes, retinopathy, and other problems with the eye, in the lungs, pulmonary hypertension, acute chest syndrome, the heart can be affected. You can have the blood system itself with anemia and other problems. Your spleen doesn't work well, and that means the spleen is the body's police man, or the justice system, or the police system. And if you don't have a good policing system, then infections can overtake our body, and the pregnancies can be complicated, our skin can be affected, joints are affected, things like avascular necrosis and other things. There's delay in puberty, so there's a lot of issues with reproductive health, and of course kidney issues. There are many, and that's what we're going to speak about soon: gallstones, liver problems, and the brain. Of course, we all know about strokes, which can be devastating, especially devastating because stroke in sickle cell can occur in children. Usually we associated with stroke with old people, but not so in sickle cell disease. Now, because you're born with sickle cell disease, you spend your whole life with sickle cell disease, and thankfully people are living into way older ages. In fact, one of the important areas to examine is how are people with sickle cell aging. We have patients in our clinic living into their 70s and 80s. The oldest person was in his 90s when he passed away. It is very multifaceted. It can be severe. There are many. This nice photograph shows us that there are many different issues that can implicate, that are implicated in sickle cell, and that can affect how sickle cell presents in a patient. But many advances have occurred in the last few years, in the last 2 or 3 decades, and gratefully persons are living longer. They are living healthier with better quality of life. Just 2 slides on how burdensome is sickle cell disease. Globally, over 7 million persons living with sickle cell disease. Annually, every year, the number of babies being born is increasing. Annually, almost 500,000 babies are born with sickle cell disease, and about 75% of these births are occurring in sub-Saharan Africa. And where these babies are born will determine their fate. So in developed countries, and even though we are not quite in the area of developed, but in the Caribbean and Jamaica especially as well, if baby is born with sickle cell disease, our life expectancy for sickle cell is in the mid-40s, going by old studies, but our patients are living longer and longer. But if you're born in certain countries in the sub-Saharan Africa, then 50 to 90% of those babies do not see their 5th birthday. But the health burden of sickle cell diseases can be effectively reduced through management and prevention programs. And Jamaica has a win in that, where our Ministry of Health and Wellness has such keen focus on management of sickle cell disease in Jamaica. Our total population of 2.8 million or thereabouts, 10% of us carry sickle cell trait, which is one abnormal gene for sickle cell disease. Why it is important when we have sickle cell trait is because we then are at risk of having a baby with sickle cell disease if we end up partnering with another carrier or another if our partner also has sickle cell trait, then we can produce a baby with sickle cell disease, even though we ourselves do not have sickle cell disease. Sickle cell disease, up to now, out of every 150 live births in Jamaica, one live birth, one baby has sickle cell disease, and we estimate about 18 to 19,000 persons in Jamaica are living with sickle cell disease. For us, I showed you an earlier slide where a lot of countries in the world, a baby might not see their 5th birthday, but in Jamaica, we have a perfect, almost perfect program where childhood mortality for babies born with sickle cell disease is no different than any other baby who is born without sickle cell disease in Jamaica. And that is a huge win that Jamaica has. What's our model of care at the sickle cell unit? To provide comprehensive, integrated, continuing care, including social support, which is critical for proper management of persons living with sickle cell disease. The aim also, through especially the Sickle Cell Technical Working Group, to execute this, our aim is also to provide equitable access to quality services where people with sickle cell disease are living, so that not everyone has to travel their way to the University of the West Indies to the sickle cell unit, but to have the same quality service wherever in Jamaica they are living, by increasing access through training, etc., by providing access to appropriate medicines. Dr. Lord spoke about the NHF and sickle cell disease being on NHF with much reduced costs for important drugs to manage sickle cell disease, etc. And of course, our close work with the peer support groups, who keep us guided and keep us grounded as to what the needs for the sickle cell communities are. Let's switch gears to our kidneys, which is a very important organ system in our body. And we have 2 kidneys. We all know this, but pardon me if I'm speaking very simply, but all humans, or most humans, are born with 2 kidneys that are located below our ribs. They tend to be the size of our fists, and they're shaped like beans. You can see them here. I hope you're seeing my pointer. We hear of kidney beans, and this is the shape. The kidney beans are named after the shape of our kidneys. What do our kidneys do? Why do we need the kidneys? And I'm sorry, I'm not seeing all of you, and our wider attendees are listening on YouTube, and I can't really ask them questions. I'm sure most of us know what our kidneys do. They act as a filter for our blood. Okay, so they help to remove from the body what is not needed, but they filter all our blood. And so they remove what the body doesn't need, right? And they return back to the blood what we need. All right, so they are a very important filter mechanism. They keep back what we need and remove what we do not need. And blood circulates through the kidney many times each day. Now, adult human beings, we tend to have about 5 liters of blood in our body, and it circulates almost 30 to 40 times through the day. So you can imagine how much liters of blood our 2 kidneys are filtering all day long. And then as they filter, they produce urine. So these are our kidneys. There's mechanisms in there that blood flows through and filters through, and whatever needs to be excreted goes into these pipes, these 2 pipes from the kidneys called the ureters. They enter our bladder. We all know about the bladder, and through the bladder, it's stored there as urine till we are ready to go and pee. And then through the pee or urine, all those products that we don't need in our body anymore are excreted. Adults tend to make 1 to 2 liters of urine each day. Through this filter mechanism, the kidneys maintain balance of how much fluid our body needs, right? Important salts and minerals in the body, it maintains their balance as well. Stuff like our sodium levels, our potassium levels, it regulates the blood acid levels. It also has other functions. It produces some very important hormones, right? Hormones that are needed to control our blood pressure. And we all know how important blood pressure is in our bodies. It makes hormones that help to stimulate the production of red blood cells. This hormone is called erythropoietin. A lot of persons living with sickle cell disease know that name. I know that. It helps to make hormones that strengthen our bones. It has a lot of very important functions in the body. And kidney diseases can further lead to heart problems, okay? If we don't have enough management of fluid balance, if our blood pressures get high, etc., it can lead to heart problems as well. So our kidneys do some very important things. And let's move straight into what happens with the kidneys when we have sickle cell disease. I just love this little diagram. I created it through my work, my PhD work. I won't bore you with it yet, except for people who might want to know what exactly this figure is showing. At the end of the lecture, we can go through it. Moving straight on to the main crux of the matter for tonight, which is kidney complications in sickle cell disease. What is unique in sickle cell disease is that the kidneys can be affected from very early in childhood, okay? Most humans, most populations would see kidney problems in adulthood, especially older adults, okay? But for sickle cell people, it's important that it can affect kidneys from very early on, okay? In the very young ages, and you might know that a lot of kids going to school, or even before that, they may be passing excessive amounts of urine. They just produce a lot of urine, especially exhibited as bedwetting. There are children with sickle cell disease that can wet bed for a little longer than most babies and children tend to. And that is mainly because sickle cell children can be producing excessive amounts of urine. We guide our teachers and face at this thing. I hope educators are listening in. We send this in the teacher's guide for when they have a child with sickle cell in their classroom. Please don't get too upset if the child needs to go to the bathroom more frequently than other children. They need to, because they are making excessive amounts of urine. You need to let them go and pee. Okay, but when they pass excessive amounts of urine, we have to be cautious because it can lead to dehydration. And why do they pass excessive amounts of urine? My slide before this showed us one thing that the kidneys do, which is to maintain balance of fluids. But kidneys in early childhood may not have a good concentrating ability. They are not concentrating the urine and retaining back as much fluid as they should be. And so excessive fluid is being lost. That is why we encourage even our children to be drinking more fluids at school, and teachers to be trained to say, hey, you need to be drinking. Because they're making excess urine, they're losing excess fluids, they need to keep drinking to put back the fluid in their body. Sickle cell people have a higher risk of urinary tract infections. They have a higher risk of infections on a whole. And so UTIs or urinary tract infections or urine infections are more common in persons with sickle cell disease. They may have a condition we call hematuria, which is just a fancy word that says there's blood in the urine. And a lot of times they'll be passing blood in the urine and they won't see it, okay? It is microscopic, they can't see it. We can only see it under the microscope or by special testing, like with the dipstick, or sometimes they'll have so much blood that they can actually see it, which is what we call frank hematuria. A patient can look at a parent might see it in the toilet and say, oops, why is there blood in my child's pee-pee? But this can happen in adults as well. Another complication they can have is what we call acute kidney injury. And this can be pretty dangerous. And many times when persons with sickle cell disease are having an acute episode, some of which I mentioned in my earlier slides, like the acute painful crisis or acute chest syndrome. So when they have an acute vaso-occlusive crisis, then they might have acute damage to the kidney at that time as well. And it's very important for healthcare professionals to look out for that, especially when a person is hospitalized with one of these problems like acute chest syndrome or a painful crisis. We need to monitor the kidney function to see whether the kidney is getting a hit at that time as well. Most times it will revert back and resolve, okay? Another complication that occurs is that they might be passing out proteins in the urine. We said earlier that the kidneys are a filter. They filter the blood in an effort to remove what the body doesn't need, but filter back and keep back in the blood what the body needs. Now, no one should be having proteins coming out in their urine. The kidneys should be retaining them, not filtering them out. But certain conditions, it happens in diabetes, it can happen in hypertension, but in sickle cell disease as well, the kidneys can leak proteins out in the urine. Sometimes they can leak so much proteins in the urine that the person ends up with a syndrome we call nephrotic syndrome, and it needs particular attention. Then, as persons with sickle cell live longer, they can end up with slow progressive damage to the kidneys, usually can result in what we call CKD, or chronic kidney disease. And there is an entity called cancer, a particular kind of cancer called renal medullary carcinoma. Thankfully, it is a very rare condition. It can occur in people with sickle cell trait as well. I said earlier that most persons with sickle cell trait don't have any medical complications. They live like non-sickle populations, but there are a couple of things that, that they should know of and what their healthcare providers should know of. And renal medullary carcinoma, which is a very devastating cancer, can occur. Here's a little bit of a fancier slide that I just want to bring your attention to very quickly. It basically repeats much of what I said in the slide before this, that some of the kidney or renal manifestations, hypocynuria, just means urine that the kidney has not been able to concentrate properly, passing excessive amounts of urine. Usually it is a reversible condition, but if it goes on beyond 15 years of age, it might become a little irreversible. Comes up as bedwetting, important for doctors and patients and families to assure this child that this is not something to be, you don't have to feel ashamed of the fact that you're wetting bed, and your doctors and nurses will train you how to train your bladder so you're not wetting the bed too much. They can have hematuria. I hope everyone remembers what hematuria is. Tends to happen more in those greater than age 10. And it's because certain parts of the kidney may be having necrosis, or bits may be dying and come out in the urine as blood. Renal medullary carcinoma usually occurs in young ages, tends to be seen a little more in boys, and it tends to have very poor outcomes. By the time we pick up the diagnosis of renal medullary carcinoma, we are not able to do much to modify its course. Thankfully, it is rare, but something we must know of. UTIs, we said, can occur at any age. Many times people will be passing bacteria in the urine without any symptoms. You know, usually UTIs can come with pain, can come with burning when we pass urine, may have pain when we pass urine, may have a little bit of blood coming with the urine, but many times it is asymptomatic. But if it keeps there, you know, just brewing in there in the bladder or so, it can lead to sepsis as well. It can you know, lead to infection in the blood. And usually it's important for us to watch out for it, but usually can be resolved well. We spoke about acute renal failure, especially when you have an acute crisis. It can affect the kidneys as well, and we need to be alert to it. And then CKD, or chronic kidney disease, can present early with microalbuminuria, which is passing small amounts of albumin. Albumin is a kind of protein. Remember, we said the kidneys might start excreting proteins, that they're not supposed to excrete. They should be retaining back the protein, but many times that filter mechanism is not working too well, and there's damage, and so it's filtering out the proteins. And the more proteins we pass, the worse we can damage our kidneys. And it's important for all of us to know, for patients to know this, because of people with children, with their family members who have sickle cell. It's important for us to realize that sickle cell with time can affect our kidneys. We can be passing protein in the urine. Simple tests in your doctor's office can alert us to this, and there can be things we can do to reduce how much our kidneys are knocking out the proteins in the urine. There can be things we can do about it. We're going to talk about it a little later. What's the burden of sickle nephropathy? Nephro, speaks to renal or the kidney. What is the burden of kidney disease in sickle cell disease? It has been an important cause of illness and even death in persons living with sickle cell disease. Older studies in Jamaica have shown that in SS people, 18% of deaths over the age of 20 may be due to the kidney problems. In the US, 4 to 5% of persons with sickle cell disease have been shown to develop end-stage CKD, chronic kidney disease. In Jamaica, by the time our SS patients are in their mid-30s, 6% have CKD. So you can imagine by the time they get a little older, reaching their 40s and 50s, a lot more are going to have that. In very older studies, and this is study from one of the studies that Prof. Sargent led in 2007, in patients with sickle cell disease over the age of 60, 85% of them had kidney problems. Life expectancy after chronic renal failure is just about 4 years, even if you go on dialysis. Fewer patients in the past with sickle cell disease and renal failure or kidney failure are offered curative therapies like a kidney transplants. And so early detection for kidney problems is critical, because if we can diagnose that kidney problems are starting, we might be able to do things about it and delay how our kidney problems worsen. Okay, so how do we manage the kidney complications in sickle cell disease? From childhood, every time you go to the doctor, and that's why we encourage at our unit and everywhere else, it is written in our guidelines. It is critical when you have any chronic illness, but right now talking about sickle cell, if you or your child has sickle cell disease, any person with sickle cell disease must go for routine visits to their doctor. Routine visits mean not when you're ill. You must go to the doctor when you're ill, but when you're well. When your doctor says, I need to see you back in 6 months, make sure you find that yourself there in the 6 months. If you have to miss the day you got the appointment for, change it. Call in early to say, listen, I have an important exam on that day. Can I make another appointment? But do not miss your routine appointments, because this is when your doctors and your nurses can ask you certain very important questions, do your physical examination, and do some simple tests that might pick up kidney problems in their early stages and many other problems. Okay, but today we are talking about kidney. CKD symptoms may be asymptomatic in early disease. Even some blood tests for kidney tests may not show much problems, but there are other earlier tests that we do that can show us whether the kidney is starting to take a hit because of sickle cell disease. But some of the symptoms when patients have stage 3 or more chronic kidney disease, they might have weakness, they might have excessive tiredness, more than what they are used to. Their feet may be swollen, their abdomens might be getting bloated, they might have poorer appetites, they might be more prone to getting infections, and their general quality of life may not be as good. But the other thing is, when an individual has sickle cell disease, it does not mean that individual cannot get other illnesses, that you can't get diabetes, or you can't get lupus, or you can't get HIV or hepatitis B virus. So some of the other things that your doctor will look out for if they see that your kidney function is going down is examine you for other problems which can worsen kidney issues as well. What are some of the tests that we might do? Urine tests are very important. A dipstick urine test can be done in any GP's office, and we do it at the sickle cell unit as well. We ask you to pass a little bit of urine in a small container, and then you take it to the nurse, and the nurse ticks a dipstick, a piece of filter paper, and she or he can test the dipstick and look for the presence of blood, or presence of proteins, and few other things. And we at the unit in our guidelines state that this must be done annually at the very least, once you are 4 years and older. Of course, if there's something happening and a 2-year-old with sickle cell comes in and something is happening, you might still need to do a dipstick urine test. But if all is going well, then every year after you're age 4, you're going to do this urine test in the doctor's office at least once a year. Once you're 10 and over, and you have not had any kidney problems to speak of till 10, then every year we're going to do the same protein test for proteins, but this is a test that we're going to send to the laboratory for a little more sensitive testing for protein in your urine. And usually we require an early morning urine sample to send to the lab to test for proteins coming out in the urine. And there are some blood tests that are done, some annually, some every 2 years. And the important tests for kidney function are, of course, your blood count that we do pretty regularly in people with sickle cell disease, your creatinine levels that speak directly to your kidney function, uric acid levels, your electrolytes, things like your sodium and potassium are your electrolytes, and then protein levels in the blood, how much albumin you have in the blood, how much globulin you have in the blood. And through these blood tests, we estimate what we call the GFR, which is the glomerular filtration rate. Remember, we said glomerular are tiny bits within the kidney. And this is really measuring how the kidneys are filtering. Remember, we said kidneys are your filter. So the GFR assesses very closely how well your kidneys are filtering. Okay, and then there might be other tests that the doctor might recommend for you to do, an ultrasound or certain kind of kidney scans. And ultimately, there might be a few people that require what we call a biopsy, where a specialist will take a bit of your kidney to send it for pathology testing to see exactly what kind of issues or what kind of disease the kidney might be having. Not every patient with sickle cell is going to get that. Very few people with sickle cell are going to end up with a biopsy, but these tests are kind of sequential. If we think there are certain problems that a person with sickle cell disease is exhibiting regarding their kidney, through the urine test, through the blood test, then the ultrasound and scans might be the next step, and biopsies for certain more significant kidney problems only. And then what do we do about it? Okay, so those are some of our assessments for kidney function for when we see people with sickle cell disease in our offices. But then what are we going to do to manage kidney problems? So we have kidney problems. Are we able to do anything about it? Yes. Number one is lifestyle. We don't really want to hear about lifestyle, including me, because it seems to be the hardest thing to do. It's much easier to pop a pill than manage my lifestyle. All right. But I think it is nothing. We all know, I don't need to tell you this, that lifestyle management is critical for management of most chronic illnesses, whether it is diabetes, whether it's asthma, whether it is hypertension, whether it is sickle cell disease. So adequate hydration, we need to avoid dehydration. If we get very dehydrated, we will damage our kidney. We will damage our kidney, okay? Even if you don't have sickle cell disease. All right, you get very dehydrated, you're going to damage your kidney. Healthy nutrition. Be cautious of overweight and obesity. I say it in every time I speak with this group, that in our recent studies at the unit, we have shown that over 20% of our sickle cell population is overweight or obese. Remember, sickle cell people used to look scrawny. Remember, people used to think, boy, everybody looks scrawny and thin, but not so anymore. All right. Overweight and obesity. Be cautious of it. It's not a good look for sickle cell disease. Limit the salt intake and limit processed foods. Okay. Preferentially go for fresh fruits and vegetables, diets with whole grains and low-fat foods. Just a good, healthy nutrition. Keep physically active, whether you walk, whether you bicycle, swim, dance, or go to the gym, but keeping physically active is very important, okay? Avoid the smoking. Smoking is never good for various things. It's not good for any human, but for sickle cell disease, it can have a lot of problems. And the smoking is not good for your kidney health either. And limit your alcohol intake. I would like to say stop it. And I think more and more research studies in the world are showing that no alcohol is good anymore. Remember, we used to speak about taking a drink a day, or, you know, a small amount, or a red wine. More recent studies are showing, and other doctors on the call can say yay or nay to me. I don't know what Dr. Fisher will think about it, but recent studies are showing that no alcohol is good. No red wine, no at all. Just forget it. Routine checks, I've said this already, very critical for early detection of problems. Dr. Leslie King is head of our clinical services at the sickle cell unit. And when we are short-staffed or something needs to cut, out of the 4 doctors, we only have 2 doctors remaining, or out of our 3 nurses, we only have 1 remaining that day for some complication, then she might shut down the daycare for acute problems, because those patients can go to the emergency room to manage those acute problems. But her preference is to keep the routine checkups going, because it is so important to see the doctor for well visits. Managing your sickle cell disease is important, okay? Managing the sickle cell disease is important, because if the kidney is worsened by sickling, then we want to limit how much sickling we avoid, okay? How much sickling we allow our body to go through. You know, we talk about dehydration, making a sickle more, infections, stress, etc. So limit the sickle cell disease. Avoid medications that may stress the kidney. Okay, there are many medications, but especially one type of medication that our sickle cell people are exposed to a lot, because pain is a big problem in sickle cell. Babies and little children with sickle cell will have pain. And so as a result, we end up using a lot of painkiller, and a particular kind of painkillers, non-steroidal anti-inflammatories, or NSAIDs, like Brufen, Voltaren, Cataflam, etc. Too much of that can stress the kidneys and cause kidney damage. It is important to keep our blood pressure under good control. Now, if the kidney is damaged, it can increase your blood pressure. And the higher the blood pressure, the worse it can damage the kidney. So if we have blood pressure, because high blood pressure is a common problem in Jamaica and in the Western world, we need to control our blood pressure properly to prevent further damage to the kidney. Identify other risk factors. If we have diabetes, we need to control that as well, because that is a double hit on our kidneys. Prevent infections. So stay up to date on your vaccines, seek early treatment for infections, which we have said earlier can all worsen kidney health. Now, there are some medications that we can use to help our kidneys retain good health or prevent progression. You know, how quickly the kidney damage is occurring, we can slow down that damage. Hydroxyurea, we have spoken about this many times. Dr. Lord spoke to it. It is a game changer in the management of sickle cell disease. And we said already that if we control our sickle cell well, we can lessen the damage to the kidneys. So using hydroxyurea, if you have never used it before and the kidneys start showing little problems, then your doctor is going to say, you know what, time to put you on hydroxyurea. If you didn't take it already, let's try hydroxyurea. When your kidneys start pushing out protein in the urine, and we say, oops, we're not supposed to see any protein in the urine, we start seeing some protein on the dipstick or whichever way, you can't see it with your naked eyes, we might put you on medications called either ACE inhibitors like enalapril, lisinopril, or other drugs called ARBs, things like losartan, okay? These drugs can lessen how much proteins are being lost by the kidneys, and so they lessen the damage to the kidneys, all right? Some of these drugs may increase your potassium levels, so your doctors will have to keep an eye through blood tests to make sure your potassium levels are not going too high. There are other medications that we use, a drug called erythropoietin. When the kidney disease gets a little more advanced, then our anemia can get worse. And so if you have sickle cell disease and your steady state hemoglobin used to be at 8, with progressive kidney damage, that hemoglobin level may start dropping to a 4 or a 5. I've seen patients with 3s, and giving them the erythropoietin, which is usually given as an injection every couple of weeks, can kickstart their bone marrow to stimulate it to make more red blood cells, okay? And remember, we said erythropoietin is a hormone that the kidney makes. And so if the kidney is not functioning well, how much erythropoietin it makes lessens. So we can give that as an injection. And giving erythropoietin with hydroxyurea could be really a good combination to manage kidney problems. There are times when we need blood transfusions. There are times with progressive kidney disease, the hemoglobins are dropping, and it might drop to a low enough level where the person starts feeling very weak, very dizzy, and very quickly we have to give them some blood as a transfusion to raise their hemoglobin and let them feel a little bit better. We need to be cautious not to increase that hemoglobin to their regular 7 or 8. That will not be good because their bodies have adjusted to lower hemoglobins. If we give them too much blood, it will put them in a painful crisis. For patients who unfortunately end up with end-stage renal disease, then we have to, if we see that their kidney disease is getting worse, their chronic kidney disease is getting worse, we have to refer them to kidney specialists like Dr. Fisher, to the nephrologist, and they will now start with co-management of your patients. There are some of our patients who will end up with end-stage renal disease and need to go on what we call renal replacement therapy because their kidneys are not functioning. Their kidney function has to be replaced. Dialysis is one way. Dialysis is a mechanism, is a treatment that replaces what your kidney is usually supposed to do, which is filtering the blood and all of those things, okay? It needs careful planning. So doctors managing their sickle cell patient should not wait too long to engage the nephrologist because they will need to put things in place in case a patient needs dialysis in the coming future. Then they should be ready to get it and there should not be delays. So we should not, you know how the health systems go. By the time they go to a nephrologist, they get an appointment to be seen, have particular tests that the nephrologist might require. We want to make sure this process starts early so that by the time a patient needs dialysis, they should be bang on in the system already. Renal transplant or kidney transplant may be something that is required for really severe end-stage kidney disease. Very important, as our kidney function declines, that we might need to readjust doses of some other medications that we usually take for our sickle cell. So doctors have to be careful and patients should be aware so they can ask these questions if your doctors forget that your kidneys may be declining in their function, okay? We might need to readjust doses of some of the medications like opioids that we might be taking, antibiotics that we need sometimes, etc. So it's very important that patients themselves know how well their kidneys are functioning. This is my last slide. Just to summarize, to say kidney problems in persons with sickle cell disease are actually pretty common. All right, as we are living longer, we are going to be more exposed to the sickling. We have longer years of exposure to sickle cell disease, and kidneys is one organ that is going to start taking some hits, but they don't have to be severe, okay? Everyone is not going to end up with severe kidney disease or kidney failure. The problems can begin even early in childhood. And the kidney is affected in many, many different ways. When we talk about bedwetting, that is not necessarily going to end up with chronic kidney disease, okay? Kidney complications in sickle cell are an important contributor to sickness in sickle cell patients and even death. Routine maintenance visits are critical. This is the third or fourth time I'm saying it in this lecture. Early diagnosis and institution of preventative and supportive measures can really delay progression to end-stage kidney disease. So we all need to work together to make sure that we have best outcomes for our patients and families who are affected by sickle cell disease. Thank you so very much for listening.
Thank you very much for such a thorough presentation, Professor Asnani. I do recall at the start of your presentation, you said you had invited Dr. Lorian Fisher
Yes.
to join you. I know she's there because she is the kidney specialist, you said. You are a general bride, so she may want to say something at this time. Dr. Lorian Fisher, are you ready to make your contribution on invitation of Professor Asnani?
Yeah, hello. I don't think I'll be okay. Not very seeing me very well because I'm actually in my
Yes, that's
car.
okay. We're getting a glimpse. We're getting a glimpse.
So I'm gonna kind of stop the video now. But yeah, I mean, kidney disease is really common in people with sickle cell disease. And I really liked that. But kidney disease is just common in general. So about 850 million people in the world have some sort of chronic kidney disease. That's about 10% of the world's population. About 15% of Jamaicans have chronic kidney disease. Sickle cell disease is one of those groups of patients that are high risk for kidney disease in their lifetime. And it starts, as Professor Asnani pointed out, it starts from childhood because you're born with sickle cell disease. What I think is really important for people to remember, especially when you go to your well visits, is the importance of detecting kidney disease very early. Because we know people living with sickle cell disease are a high risk group for chronic kidney disease, it is really important that they do the testing with blood and urine at least once a year, starting at age 10, especially if you're found to have protein in the urine. I tend to manage more adults, and oftentimes what's really sad is when people with advanced stages of kidney disease come to me, but having not had done their testing from before, right? And at the point of advanced kidney disease, there's not much you can do to slow down kidney progression into kidney failure. So it's really, really important for early detection. I think too, also empowering patients about knowledge about their kidney disease, and knowledge about how it affects them and sickle cell disease, because I think patients are going to be very, very important part of management of their own care. So it's really important for you to know, well, if I'm going to the emergency room for whatever reason, you need to remember to tell the doctors in the emergency room, if you know you have kidney problems, say, hey, I have a kidney problem. And so medications like Voltaren or Cataflam, I should not be getting, right? So really important to know about your disease, because you will also help along the process, the healthcare process. So, it will cause improved outcomes. I must say though that people with sickle cell disease are very, very high risk of developing kidney problems. However, people with sickle cell trait may also be high risk, usually clearly not as high as sickle cell disease, but people living with sickle cell trait also are at risk for intermittent blood in the urine, and they're also at risk for chronic kidney disease later on in life. Whereas people with sickle cell disease, they have it younger, in their 20s, 30s, even 40s. People with sickle cell trait may develop kidney problems maybe in their late 40s to 50s. So it's really important that people who are sickle cell trait be also checked in adulthood, not like in sickle cell disease in childhood. In adulthood, they should be checked at least with blood and urine for kidney problems.
You're muted.
I'm muted.
I didn't hear that just now.
Yes,
And
Dr.
the
Fisher,
question.
what if you're going through life, you're 50, 60, 70, you had no idea you had the trait, and then you start developing kidney issues? Is that a possibility that somebody could go through life more or less
Yeah, it's
healthy?
quite possible. It's quite possible. And that also argues that people also over the age, is this controversial? So who should we be checking? Everybody for kidney disease because it's so common. So people who are over age 50, 55, in a lot of the current recommendations, anybody who is over the age of 60 should be checking for their kidney function. But yes, I mean, people with sickle cell trait do not know that, oftentimes don't know because they're usually relatively asymptomatic.
So Prof. Asnani, what if you are 50 or 60, 70, and you said, let me check to see if I have sickle cell trait? Does that make any sense?
Absolutely, why not? Sickle cell trait, I think Dr. Fisher really highlighted a number of things. One is just forget sickle cell disease or trait. Everyone, the burden of kidney disease is so high. And I know she's very passionate about building awareness about your kidneys. But so number two, our mantra, our, tagline with when I say our, it's no longer only the sickle cell units, but even our Ministry of Health and Wellness, know your status. The need to know whether you have sickle cell trait is especially important if you're a young person.
Right, particularly if you're thinking of having children.
It is critical.
So hang on there now, Prof. So if you have found the partner of your life, or so you think,
yes,
both of you should go and check if you have sickle cell trait, shouldn't you?
Absolutely.
So it is not just the that document that you're going to sign to say if the marriage doesn't work, then you need to get X, Y, and Z. You really ought to go to check, both of you, if you have sickle cell trait, because if both of you have it, there's a likelihood that if you have children, the child will come out with sickle cell disease. Am I correct?
Absolutely, 25%
learning.
chance. If you have sickle cell trait and your partner has sickle cell trait, you have 25% chance that your child is going to be born with sickle cell disease. Now, and there are countries in the world like Bahrain and so on, some in the Middle East, where it is mandatory premarital screening for sickle cell as well. And I think they heavily recommend that you don't get married. My very basic and simple mind, I would say to my patients that, you can't determine who you're going to fall in love with, but maybe you can be a little bit more thoughtful about having a child. That's very controversial, I know.
I know, yes.
So many questions, but you have to be, but you should at least know your risk that you might end up with a child with sickle cell disease, because up to now, a lot of our parents who end up with a baby, because we now have universal screening for sickle cell, every baby being born in Jamaica is being tested for sickle cell disease. And a lot of parents are still so dismayed because they never saw it coming.
Yeah, but
And
this
so
has been going on.
Just a minute, Prof.
Before,
just a minute, I need Prof to elaborate on testing, not only for sickle trait, but for other abnormal hemoglobin. So it should not just be a sickle test, but it's the hemoglobin electrophoresis, which would identify any abnormal hemoglobin, because you reference the C
please.
trait,
Talk to the people.
the
Blood problem.
beta plus, the beta zero, and those abnormal hemoglobin are critical.
So, Moret, we're talking about blood.
Yes.
So talk to the people. You see, when we talk over their heads, we don't reach them. So you're saying all kinds of tests on the blood should be done. Am I hearing you correctly, Moret?
No.
What are you saying, Moret?
Speak to the matter.
Okay, so they can be sickle hemoglobin. So when we are in our mother's womb, when we are a fetus, we have a hemoglobin called fetal hemoglobin. When we are born and we come into the world, that fetal hemoglobin gets replaced by what we call adult hemoglobin. That's hemoglobin A. Okay, we label that as hemoglobin A. Most of us will lose all of our, almost all of our fetal hemoglobin, and we live our lives having hemoglobin A. If a child is born with sickle cell disease, okay, their fetal hemoglobin, by the time that fetal hemoglobin disappears after birth, their hemoglobin that they end up living with is called sickle hemoglobin. Sickle hemoglobin is only one type of abnormal hemoglobin. That's the S gene, okay? If you get two S genes, you will have SS kind of hemoglobin. But remember, I showed you that there are different types of hemoglobin. For example, what happens with SC? So C is not a sickle hemoglobin. But with the S and C, they have a sickle hemoglobin and a C hemoglobin. Now, a sickle, there are different types of tests for hemoglobin. When we say have a sickle test, that test is only going to look for the S, the presence of S hemoglobin. But a wider test, which is a very common and simple, easily available test, hemoglobin electrophoresis, can check for all different kinds of hemoglobin. So, say, for example, if I have hemoglobin C trait, I have one A and one C, AC, that's not sickle cell trait, but it is the hemoglobin C trait. And I'm going hunky-dory because it gives me no trouble. I end up, and my husband has the S trait, AS, sickle cell trait. I can have a baby with SC disease, which is a type of sickle cell disease because there's one S gene, the sickle gene. That's what Moret is talking about. So when we want people to know their status, understand not just the presence of sickle cell trait, but understand if you have other abnormal hemoglobin as a trait, because if you get married or have a baby with somebody with a sickle trait, you have the same risk of having a baby with sickle cell disease.
I looked at a few of the comments on, sorry, you wanted to say something, Prof?
Oh, no, go ahead, go ahead.
Yeah, I looked at a few of the comments on, there weren't many, but, and there are clearly some people who are either part of the sickle cell community or family of part of the sickle cell community. There's somebody who said, teachers still don't know or care though. And I would be a little kinder to the teachers. I think both the Ministry of Health, people like you, Prof, and others need to partner with the Ministry of Education, particularly when I saw that story about that teenager at her school and the distress that she was going through and her mother because she had to leave the classroom so frequently to get to the bathroom. So there needs to be something, and I made a note with the Ministry of Education, the Association of Principals, the Guidance Councils Association, Parent-Teacher Association. There's something needs to be there. And we need to speak the language that people can connect with readily. You know, that is very important. So one other person said that it was this, Trish Allen says, very informative. Thank you. Thank you for watching, Trish. Let me see what else here. Right. There aren't any other questions. I think people just watched. At this point, we have 32 people on.
So the point about going to the schools and Ministry of Education, extremely valid, but not something that has been forgotten or ignored. The Sickle Cell Support Foundation themselves have been very keen on it over the last couple of decades. They actually have produced a teacher's guide many years ago that can be given to children. I think we're out of print now. Nothing to say we can't print more copies, right, Moret?
We have soft copies.
We have soft copies.
Okay.
We also at the unit have a brochure that we can stick on to every child who comes to our unit for sickle cell, just a checkup. We give it to them to give to their teachers. In more recent years, again, especially through the technical working group, Dr. Lord and Moret can jump in. There have been many training sessions and talks given to school nurses. I think Dr. King did one up to last week. And wherever they can reach, Prof. Madden has gone into schools and given talks. We were at NCU last week doing some training and testing. So Whether it is a very coordinated effort yet or a very, really a direct effort with the ministry, I'm not sure. And I'm sure we can really increase and make that effort much more powerful, but it is not an area that we ignore. Maura, you want to say something? Dr. Lord, if she's there, she can.
Okay, so just to say, we agree that it's an ongoing effort to get the desired behavior change. But earlier this year, through the Sickle Cell Technical Working Group, there has been a partnership with the Ministry of Education, and it's all regions. So it was actually Prof. Knight Madden who conducted the training, and the training targeted all the professionals in the educational sector, principals, teachers, guidance counselors, school nurse. And out of that, the Nurses Association requested their specific training, and that training actually took place last week. However, it requires ongoing intentional effort to get the desired behavior change. And it is a chronic need, because if the school experience is not harnessed, then that will result in the socio-economic burden for persons living with sickle cell disease. And so I think we need to accelerate the effort to target the educational sector.
Yes, yeah, I think so too. And it's not just the people with sickle cell, but as all students, there should be something, maybe at the start of each academic year, when there's a little talk about it, so, because you might see your classmate having a hard time, and children can be brutal and cruel, and the child is getting up frequently to go to the bathroom, and rather than show some empathy or saying something unkind. So it's not the people who have the sickle cell and the families, but everybody needs to know what's going on. Yes, and we're going to have to work on it. Note that I said we, like I'm part of this thing.
Of course you are.
Yes. Actually, if I may,
One of the
just to
things
say
I
that-
want us to do is speak to the populace on the platforms that they use, social media, with bite-sized pieces of information, with a language that is easily understood. Because all of that research, as you said earlier on, you're coming out of research, that's your area, and of course, you're a medical doctor. But when we talk, let me give you an example of something that is unrelated but related. Years ago, I was doing some training for the Jamaica Public Service Company. I went down to Montego Bay, years, maybe 25 or more. And this didn't happen to me, but it was told to me about a senior citizen who had gone in to query her bill, right? Because she thought it was much more than she should have been paying. And a very professional, well-trained, polite customer service rep was dealing with her. But something was missing, and this is what happened. So each time the professional spoke with her and told her what it was, why the bill was where it was, the woman looked more and more confused. And again, I said professional, polite. I mean, you couldn't have wanted a better rep. But you see, we have to connect with the culture, because the rep had been saying to this senior citizen about her consumption. Now, if you understand exactly, Prof. And
Yes.
so the senior citizen then, in her exasperated state, said, Miss, we might have a little sugar, but we don't have no consumption. And you see, it's a
Yes, yes.
serious thing. And because I work in communication and work in language, we have to talk to people with a language that they understand. I don't know how many people use the term consumption anymore. I would say people of a certain age would use it. And so when we are devising messages and communication for important things like health matters, we have to talk to them using the language that they understand.
Yeah.
That was such a profound statement. And people think I'm usually very, "Oh, why you have to get?" I said, because if you don't, you have to talk to people with the language they understand. Mark you, the other side of that story is that you could be standing up with a bunch of young people, 18, 20, and they're talking and you have no clue what they're saying.
Absolutely, I don't.
That's another story. You know, so we have to get, if it is young people who want to reach, we have to get the young people in that cohort to help us with the message. And then we have the people who are 50 and 60. We have to remember what that language was and talk to them. The language sometimes changes, but we have to stay in touch. You know, anyway, I'm not giving a lecture, I'm just telling you what my experience has been and where I think we need to take this thing. Right.
Dr.
Good.
Lord wanted to, Dr. Lord is here as well. Dr. Lord, you wanted to say something as well, right?
Yes, I
I see
was
her
about to
smiling.
say,
I wonder if she knows what consumption is. Dr.
yes,
Lord, I'm being
yes.
really out of order.
We understand. No, I was speaking as it relates to the updating parents. Is not only on the national level that we will conduct these awareness with the schools, but also we have the parish coordinators and the regional coordinators for sickle cell disease that will conduct it even closer within the classroom setting with the students and the teachers, that we will have these increased awareness happening across the nation. So the message is being spoken, especially when we have the World Sickle Cell Awareness Day in June and the activity, the World Sickle Cell Awareness Month in September. This is at these times it is being heightened.
Okay.
Yeah.
Okay. I'm glad to hear that. Very glad to hear that.
And it's not only with the persons that we will normally have that sort of awareness. We try to raise awareness among healthcare workers, whereby we will conduct training sessions for the various category of staffs. For example, we will have the community health aides that go out in the community, right? We will have training for them by themselves. So they'll be able to speak to the households when they go out to do the home visits.
Yeah.
This is in addition to the other healthcare workers that will work in the medical field. Huh?
Yes.
So actually Friday, the 30th, not Friday, on the 30th, Tuesday the 30th, we would have one national training for the healthcare workers across the nation. And so this is as part of our World Sickle Cell Awareness Month activity also.
Yeah.
Over.
Maureen, I'm just wondering, when was the last time a feature or a documentary was done on sickle cell? I go that way because I used to teach students at Karamak about documentary making. Giovanni Dennis, who took it seriously when I said to him, it's a dying art form. And he took it on seriously. But maybe it is, Maureen, make a little note of that. Let us see.
Yes, I will note and we'll talk,
Yeah,
Faye, and you
little
can
note.
help to
No, we have to
influence
do it
this
in
process.
drama form. We have to do it in drama, Miss Faye. That's where
Yes, that too.
we have
That
to
too.
documentaries, but we need drama.
Yeah, but you see the drama, but the drama can be in the documentary because the documentary can have drama as an aspect of it. But the thing is, that documentary cannot be put on traditional media alone. It has to be put on Facebook. It has to be put on because that's where we reach people now. Things have changed, eh?
Yeah,
I still have, because of my age, I still have appointment television. I sit to watch the news at 7 o'clock. Nobody under 40 does that. They don't even own a TV. Most of them don't own a TV. It's fact.
That's right.
You understand? So we have
We
to
also
reach them.
have to do reels. We'll have to do
Exactly.
reels to get them
But
in
we need
bite
to-
sizes as
Exactly.
To
well.
make drama around sickle cell for better consumption.
Yes. Right. And I know Professor Sargent will be so happy to see that we're using the technology to get the word out and get the information out and help people to take care of themselves. Well, guess what? We've come.
Hey, there are 3 points on YouTube, and I have a comment question.
Okay, let me go back to it. Go ahead. Go ahead with it, Moret.
Okay, so Prof,
yes, I'm finding it now. These came up recently. Natalie Warren, you spoke to overweight or obesity. What if you're gaining weight in hydroxyurea?
Good. So happily, children who are not thriving, and that's one of the issues with stigma or other kids being bullies, because our children may grow a little bit slower, undergo puberty a little delayed. So when they're on hydroxyurea, they're going to run around like regular kids. But, childhood obesity is a huge problem. It's not only emerging, it has emerged now as a big problem globally, including Jamaica. So when you're on hydroxyurea, your sickle cell disease does much better. And so you can put on weight, but through healthier lifestyle changes or healthier lifestyle activities, you're going to maintain a healthy weight through eating right, not just junk food, through exercising, through being physically active, just like all the rest of the population needs to do. So you're not going to gain weight because you're taking hydroxyurea. You might gain weight because hydroxyurea is dampening your sickle cell, which is what we wanted to do. But that does not mean we take on all the unhealthy lifestyles, Natalie. So that's what we need to do. We need to maintain healthy lifestyles. Yeah.
So Trish Allen says, I have a challenge receiving medications from the sickle cell unit prescription at a public hospital. The pharmacists consider the prescription to be from a private unit.
So if and this is again a win for the sickle cell unit. The sickle cell unit resides on.
I'm sorry, she continued. She says, I usually have to ask a doctor at the hospital to rewrite the prescription so I could get my medication.
Yeah, yeah. So the unit is at UWI. It's not a Ministry of Health unit. It's not one of the public health clinics. But in the recent, just very recently, for all prescriptions that are written at the sickle cell unit can be taken to a drugstore pharmacy, and they will be filled free of cost, just like it was coming from a public pharmacy. So all the other places may not honor it, say a hospital. The second thing is that we encourage our patients because of other things. So our prescriptions are now being honored in the public healthcare system at the drugstore pharmacies. But there are other requests that we make, say for x-rays or blood tests, that are not yet being honored in the free healthcare system, in the public healthcare system. But we do encourage our patients who come to the sickle cell unit to also be registered at their nearest health centers, where happily, I'm very happy to hear that her doctors are actually facilitating this, writing the prescription, but you'll have to be registered at that center, have notes, have your regular medical records there so that doctors can actually help you in accessing those things. But that is it. But if you went to a drugstore prescription, it will be honored.
Once you go to DrugServe, you will get it there. Thank you, Trish. Really appreciate it.
Correctly, Dr. Lord, because she is part of that win. Yeah.
Yes, I agree. That is true.
So Trish, Alan, thank you so much for your contribution and for everyone who made a comment. I'm not certain, Trish, you had an earlier comment. I said, wow, I'm not certain what that was related to, but thank you so very much. We've come to the end almost of what I think has been another very important evening with a really, really informative lecture. And if you joined us from the beginning, the good thing about YouTube is that this lecture will be up. So what we can do, we can send the word around. I'm always about sending the word around. Send the word around. The thing has been done, but it's up, and we can get people. And we have to also get people from outside of the sickle cell community to watch, to listen, to learn. Because when everybody is informed, then we have a healthier society. We have a healthier society. So, right. Are there any other questions from anyone here in our gathering or comments before we close off? And we really want to thank Dr. Lorianne Fisher, our kidney specialist. Usually, we didn't find a lot of wait, I see Londian up here. We don't normally see a lot of, well, I'm dating myself, 30, 40 years ago, we didn't see a lot of women who were kidney specialists. Am I correct? Things have changed and are changing. I'm so happy to see that.
Now, thank God.
You're correct.
Female surgeons now as well. That's what we never used to see much of.
And female urologists too.
Yes. When I said, wow, good. Wonderful. Ladies and gentlemen, have we lost Davian? Davian, are you there still? We want to thank you very much for your introduction of our keynote speaker, Professor Monica Asnani. Prof, thank you so much. You spent a lot of time preparing for us. There's a lot of information. I followed, I took notes. I don't know why I'm taking notes. I took notes, and even when Dr. Lord spoke, I was taking notes. And then in your slide, when she said 1 in every 150 living with sickle cell, and your slide supported that. And then she also said 1 in 10 carrying the trait, and your slide. So I said, oh, them know what I'm going to deal with. Yes. So you
Yes.
see, I was listening keenly. I was listening
We are a
keenly.
family here.
Yeah, of course I know, because it's that kind of setup. It's that kind of setup. And yes, did you answer me? Did anybody answer me if you can end up getting sickle cell when you're 60 and 50 and 70? Can
If
anybody
you
end up
find
getting,
out you have sickle cell,
yeah,
right, we started talking about that. You said, what does it mean if you find out you have sickle cell at 50 and 60?
or can you, is it possible that you could be diagnosed with sickle cell when
Of
you're
course.
50, 60, or
Yes.
70?
So we
Sickle
gave
cell
that
disease?
side as well. So that is what the variability of the disease is all about. There can be many persons, especially with the milder forms, who just never have. So remember, newborn screening has just now started. But you know, if you're 50-year-old, you were never screened at birth. And you probably lived healthy, never knowing anything about sickle cell. And maybe you end up with a problem. Maybe you have a hip x-ray that looks a little bit, and if it's a very smart doctor says, this could be sickle cell, let me do an x-ray on you. Or let me do a blood test on you. So you can be diagnosed. And you that sickle cell really didn't give you much problem growing up and to age 50. And there are people who are found on routine insurance testing or some other
Yes.
kind of testing that might need a sickle test as well, you know.
Look at that. Look
Yes,
at
isn't
that.
that good? Yeah.
Yeah. Well, it's Moretta I'm blaming because my head is expanding.
In a good way.
Very good way. Very good
There
way.
is a question on
Another one?
YouTube from Renal.
Renal,
Not sure
yes.
how much we can answer, how we can direct her.
Could you,
Prof?
Prof and Dr. Lord, can you
Yes.
spend 2 more minutes? Renal is saying, what are the medications that are covered by NHF for sickle cell?
There are many classes, different classes of drugs that are covered. And if I don't know every single one of them, remember NHF has a website, and that but the fact that you're on YouTube means you can go on the NHF website as well. But there are many painkillers, important opioids that are covered, and many other painkillers that are routinely prescribed for patients who are having pain. That are covered by it. NSAIDs, Panadol, Tramadol, etc.
Is there any painkiller that a sickle cell person should never use? Is there any painkiller that somebody with sickle cell should never use?
No,
Okay.
unless there are problems starting. If we find you're taking too much of NSAIDs and your kidneys are starting to show a little bit of strain, that we might encourage you to take, switch around your medications, but none. There's hydroxyurea, of course, that is covered by NHF. There are certain medications that protect the kidneys. Some of the names that I gave, they are all covered by NHF. Now, remember, NHF does not mean free. It's a subsidy. But in the government system, these drugs are free. There are drugs for managing leg ulcers that are covered. There are many antibiotics that are frequently used or prescribed for patients who have certain problems that are covered by the NHF. So quite a vast different classes of drugs. I don't know if I'm missing something, but it's also on the website, because NHF has been really good in adding on more and more drugs, not only for sickle cell, but even for other illnesses. So
yeah, that is so.
Yes, but even if I could also add that even on with the NHF, we have the double subsidy for those 18 years and under. So they even have it, it's even better for 18 years and under, for persons who are 18 years and under and seeking drugs from the NHF.
Oh, double subsidy,
the availability. Yes, yes.
For 18 years and under.
Yes, persons who are 18 years and under.
Yeah. Okay. So I'm going to ask Renal and Trish and Sashan and all of you, Keynote, if you're still there, tell people about this talk and send them the link. All right. We need to get people watching this. Thank you. Miss Moret, you did such a brilliant welcome and opening remarks. Would you like to use one of your, where is she? Why is she looking as if she's frozen?
No,
Moret?
I'm not frozen.
Okay.
I'm here.
Yes.
I'm here.
Would you like to say a final word before we close off?
So certainly, wow, I'm overjoyed. I think I could say mission has been accomplished. The fact that the lecture and this exchange is recorded, it means that we can go back to the link and we can watch several times. But Prof did such an amazing job. Her lecture was thorough, it was comprehensive. I had some questions, and as the lecture progressed, I could check my questions because they were covered. So you did an amazing job, Prof. It was so informative. And the community is enriched for this experience. And what do I say about Auntie Faye, who is my friend? You hear how many times she called my name? So she has given us a challenge, and that's about documentary. And I really want us to pursue that documentary.
Yes.
And you have also initiated a thought about how we communicate. And Prof. Asnani made a call about needing you to assist us, to provide support to us in how we can more effectively get the word out. And there is a need to get the word out.
Yeah.
As a communicator, you know that the message has to be repeated countless times before persons fully understand and it translates into the desired behavior change. So there is need for more and more communication. And we have the head of the chair of the Sickle Cell Technical Working Group who supports us.
Yes.
Oh my God, unwavering support. And wherever she's to find some money, she will find it as she has a mandate to fulfill. So I think we're poised through this conversation to make ongoing impact and ongoing change. And I'm really, really excited about the future. So I want to thank you all and thank all the persons who have joined, those who have participated through their questions and their comments. And tomorrow we have another amazing session. We'll be showcasing 3 amazing individuals who are living with sickle cell, and they are doing exploits, showing that there is no limits. They're living without limits. So one, she did the prayer, educator and author. We have an attorney and a lecturer and a telecommunications professional who is also a triathlete. So he will be participating on Sunday in a triathlon in Atlanta, and he will be on in our monthly empowerment forum.
Where
so you
is
could
that?
check
How do we see that?
Right, so you can check our social media page. It's on Zoom. I'll share with you the Zoom detail. I was hoping we could have shared the flyer, but unable to share the flyer. So I'll just share our Zoom link. Faye, I'm also gonna send it to you.
Yeah.
Because I know you have your links and you can circulate.
Oh, yeah.
But the Zoom detail is the meeting ID. It's 358-895-2516. And the passcode is SConnect. That's SCONNECT 25.
Let me read that
I'll
again.
repeat. Meeting ID 358-895-2516. And the passcode is S-Connect 25. And we meet monthly, the last Thursday each month at 7 via Zoom. And it's our monthly virtual empowerment meeting.
All right. Good.
Right. So
have
we're
that.
inviting
I'll
as
pass
many
that
persons
around.
to join
Yeah.
as we have a conversation around living beyond limits, celebrating success with sickle cell.
There's living beyond limits. Okay. Okay, thank you. Well, we've stretched a bit over the 7:30 deadline, 7:35. Thanks again to everyone. Well, Moderator has done a brilliant job. And yes, we will stop seeing each other here in about a minute or so, but there's work for us to do. And yes, I did offer, and
Thank you.
I did offer. And I know Professor Asnan is going to make sure that I carry
Personal
out.
thanks. Really need to.
Yes, thank you so much. We will take up that offer. I do agree.
Yes. All the very best, everyone. Have a safe and pleasant evening. And yeah, this was good. It was good
Yes.
to have been here. It was good to have shared in the occasion. And I wish you success as you go forward with this very important project in terms of, I call it a project because it's an ongoing project to educate and inform all of us, and particularly those who need to know what's happening and how to deal with themselves, their family members. And so when I don't want anybody thinking that I'm planning to be pregnant, at my stage and age where I'm asking if I could get sickle cell at this stage. You see, none of that is in the offing. By the way, you have to learn to laugh at yourself. It's part of medicine. Take care. Walk good, everybody. Thank you again, Maureen.
Thank you. Thank you, everyone.
Yes. Thank you, everyone.
Bye bye.
Bye-bye.
Bye.